can suffer from this. It's not due to earwax, it's due to eustachian tube dysfunction, and I will come back to that in a moment. So some of the treatments I was doing on myself today is what I sometimes advise my own patients. And although I'm fully aware of how a blocked ear can affect clients, because obviously I treat clients all day and every day, and I understand how debilitating a blocked ear can be. Again, it reminded me today, first-hand experience, because it was really, quite debilitating for me today, and hopefully tomorrow it's going to be a bit better. Anyway, so this is patient one. I think I've got about 5 clients in total. So patient one, we're just in their left ear, and they've got a very narrow ear canal entrance. You can see there, it's just about large enough for me to insert my Zollner suction probe, and we're just removing some of this wax laterally near the entrance. But it was quite deep, so it was extending from the entrance all the way to the patient's eardrum, which is roughly about 2.5-3 centimetres in depth. And as I'm wriggling this wax out of the ear, I can feel the frictions, and the patient also commented they could feel this wax coming out of their ear, and that's because the surface of the wax was quite rough, and as I was bringing it out, it was grazing against the patient's ear canal. Nonetheless, we managed to remove that, and you will see the patient's eardrum there, so that's nice and healthy. And I believe this is the same patient, but their right ear. So I, again, tried to use suction here, initially anyway, but the wax plug was quite hard and dry. This ear wasn't fully blocked, it's semi-occluded. There's a bit of an opening at the tops, and the patient did feel that themselves. They did notice that this ear was blocked, but they didn't feel as bad as their left ear. So I've just glided in with an ear hook. I've managed to remove this in one single piece. There's the patient's eardrum, nice and healthy. I think I'm just going to mop up. There's a bit of dead skin there, as you can see. Similarly to their left ear, this entrance is quite narrow. So I'm just using a Jobson horn, just removing some of this debris off the anterior canal wall, quite laterally. So the anterior canal wall means the front parts. In the case of the patient's right ear, the anterior canal wall is the ear canal to the right, and the posterior is to the left. When I say lateral, I mean near the entrance, and when I say medial, it's towards the eardrum. So there's a bit of soft, dead skin, I would say this is, on the posterior lateral canal wall. Now, sometimes I get criticised for using medical terminology. You may have noticed whenever I do, I always try to translate in layman terminology. It's just that my channel, I train professionals in performing endoscopic earwax removal, and a lot of the delegates and potential delegates do watch my videos for that reason, and we have got a lot of medical students that watch, other audiologists. So, and that's the reason why I try to obviously appeal to both not only the ear care professionals, but everyone else who enjoys watching for whatever reason. I know there's a number of reasons why people watch, whether it's entertainment, or I know a lot of people the videos they find helps them get to sleep, or it helps with anxiety. So there's a number of reasons why people watch. So I'm just mopping up near the entrance here. That's the eardrum, nice and healthy. And they're the remnants of both ears. So this is patient 2. Now, I'm not sure which order I've done it in. So patient 2 looks like patient 1 in the first instance, and it's just their left ear. Now, this wax is a bit more sticky. There's a lot more hairs at the entrance. And once again, I'm using a Zollner suction probe. Because it's quite sticky, it's quite difficult to lift this off the canal wall. So I'm using a hook now. I'm trying to glide the hook in anteriorly and then superiorly, so both to the left of the wax plug and keratin plug, and then at the roof of the ear canal. I'm bringing some of this dead skin outwards. However, due to the consistency of this keratin and wax, the ear hook is somewhat slicing through it like a hot knife through butter would. So I resorted to the good old forceps, or crocodile forceps. These are the fine jaw 3mm tip forceps, so they're meant for narrow ears. And I just clamped upon the keratin plug and the wax plug, and I'm just slowly bringing it outwards. And it came out in a single long piece. And I'm just using a hook just to remove some dead skin quite laterally off the back part of the ear canal wall, so posteriorly. And that's the patient's eardrum, which is nice and healthy. And that's a still image of that wax and keratin plug. So this is patient 3. Now patient 3 had bilateral blocked earwax at the entrance of both ears. You may have noticed the patient's got a lot of dry skin, a bit of eczema, psoriasis. We call that otitis externa. After the procedure, I had a chat with the patient and they explained that they'd be getting water in the ear, so that's one of the things I've advised them to stop immediately. Recommended some cream for which they can get over the counter, so they can apply onto that dry region, and if that's not successful, we're going to write to the doctor, the patient's GP. So the wax is quite sticky, so I've just gone in with some olive oil ear spray and it's just binded this together. It is quite impacted. The patient themselves were quite surprised by how much wax that I managed to remove when they visualised it on the tissue at the end of the procedure. So I'm just trying to lift it off the canal wall, separate it to mobilise the plug of wax. You can see it's bits, as I said, it's like peanut butter. The suction probe, the tip of it itself, when you make contact with this plug of wax, it makes an impression, it indents itself and imprints itself into the wax. So I think I'm going to put some more olive oil in a moment, if I'm correct, which we'll see. Now this is lodged beyond the isthmus, so where that wax plug is, you can see at the bottom, the ear canal, it's like a little valley there, and we call that the isthmus, so at 0.5 centimetre away from the patient's eardrum. And this is the case with most people's ears. The ear canal narrows and it widens again, and this plug of wax is lodged beyond that narrowing, so it's a bit of a tease to remove, and the consistency of wax doesn't help. So yes, as I thought, I've just put some more olive oil in there just to facilitate the removal. I'm just trying to bring it down off the roof of the ear canal, you can see there, but we're going to be really gentle because again, despite the olive oil, it's just imprinting itself within the wax plug and I'm not getting a suction grip. So now I'm just lifting it off the anterior canal wall. Now, a technique that I've developed recently, initially I used to dose the ear with olive oil, let it rest for a few minutes and then drain the ear. But now, more and more, I'm actually performing the wax removal whilst the oil's in the ear. I just find it's a bit more effective now. As a result, sometimes you get a bit of blariness because the oil's in the ear and you're suctioning some of the oil out at the same time as the wax. But I find it just works a bit better. You can see it's coming out of large chunks now. Again, quite a narrow entrance. So this patient is chronic sufferer from earwax impaction. They have to attend every 18 months or so. And partly I believe it's due to the consistency, not only the consistency of the wax, because it's quite sticky as it's migrating out of the ears, sticking itself upon the canal wall, but because of the anatomy of the ear, because it's quite narrow as it reaches, and it's quite bendy at the entrance, so it reaches the entrance, and because it's a bit bendy as well, it gets trapped and you get a build-up behind it. So that's the last plug. The patient's got a nice healthy eardrum, just mopping up some of the residue. There's the eardrum in the distance. There's some little bit of wax on the back part of the ear canal wall. So this is mid-canal. Just quickly suction that up. A bit of dead skin there. We're on the cartilaginous portion, so I can put a bit of pressure on there without it being uncomfortable for the patient. This is where all that dry skin is there, so we recommend some cream, as I said earlier. The patient's hearing significantly better, they're very happy. That's their left ear. And now we're on to the patient's right ear. Same story, the entrance is really dry, a lot of psoriasis, dry skin, so we call that otitis externa. They didn't have much otitis externa within the ear canal itself, so sometimes people can get the dry skin in their ear as well, on the external auditory meatus, which is the ear canal. But in this particular case, it's more externally at the entrance. The patient says, explained to me sometimes because they scratch that area consistently, it weeps as well, and it's kind of like a vicious cycle. I know when you've got an itch, it's easier said than done not to scratch an itch, but this cream that we recommended will just kind of almost numb the ear a bit somewhat. It's not an anaesthetic in any way, it's the wrong phrase, but it will just calm the ear down. And so if you've got an itch, you apply it and it will just stop the itch. And that's how sometimes things can heal themselves naturally, letting nature take its course. So just remove the big plug there. There's the eardrum in the distance. Again, you can see it's quite a bendy ear. You can see to the right, the ear canal turns to the right, it bends to the right. It's just mopping up near the entrance. And in a minute, you'll see another good still image of all the debris that are removed. Here we go. You can see just how dark that wax is, especially the top plug. That's from the patient's left ear. And the darker the wax is, the longer it's been in the ear, it's oxidised, it's matured. This is patient 4, I believe now. Again, quite narrow ears, a bit of dry skin in there. If I remember correctly, this patient was a bit unsteady with the head. And that's quite common in procedures. And so when we train our clear wax delegates, I explain to the delegates that you have to get the patient in the position you want them to be, because you're going to be doing this procedure all day. And instead of having to twist your body and neck for the best part of the day, which in the long term is going to affect you, trying to get the patient to be in the position you prefer. Obviously, we don't want the patient uncomfortable, but with this patient, it's just they just had a tendency. Some people have a tendency, they're not aware that they're doing it, but their head would move quite a lot during the procedure. So on occasions, I had to come out and just reposition the patient. And you can see the patient's got a lot of hair. It's quite matted. It's really impacted, actually. They do wear hearing aids. Ironically, they went to see their local nurse because they weren't hearing very well. And I don't know, sometimes you've got to take it with a pinch of salt what patients tell you, but the patient said to me that the nurse said there is a clear, and this is only like a couple of weeks ago, and the patient was still obviously experiencing difficulties hearing. The hearing aid was whistling, which is quite common if you've got earwax, because the sound that's amplified by the hearing aid hits the wax and it reflects back out of the ear, re-enters the hearing aid microphone, and the hearing aid re-amplifies it, and we call it a feedback loop. So I've got the lateral plug of wax. It's quite dry, it's stubborn, there's loads of skin adhesions. I think I'm going to use the ear hook, if I'm correct, just to help facilitate this, but I think in the end I do manage to remove the majority of the plug with microsuction. So I'm just using the hook. I'm just going to the back part of the ear canal and then to the roof. I'm trying to embed the tip. So again, you might notice this ear is quite narrow. I've seen quite a few narrow ears today, actually. Think about it. So although the hook didn't remove the wax, it did dissect it somewhat. It broke it up to little pieces. So I'm just going back in with the Zollner suction probe to vacuum some of that. So I'm just trying to wriggle this out. And with this patient, the medial part of the ear canal, the size of it is more or less normal, but it's the lateral part, so the entrance, the first third, the cartilaginous portion, that portion of the ear canal is a bit narrow, but beyond that it's wide, and that's why it's a bit tricky removing this plug, because the plug is actually larger than the entrance of the patient's ear, because this plug was building up and forming in the medial part, so the deeper part of the ear canal. So I've just gone in with the hook. Again, I just sliced through it. So just going back in to mop up with the Zollner suction probe again. So whilst you're watching this, I'll just go back to my own ear problem. So yeah, I woke up middle of the night with severe earache. It actually woke me up because it was that painful. I had this about 10 years ago. I remember, I was at university in my second year, so it would have been 2000... God, it's a long time ago, guys. 2005, I believe. So it's more than 17 years now. Surely that can't be right. No, it's right. That is correct, isn't it? Oh, wow. Time does fly. And it was very similar to that time. So now, people with eustachian tube dysfunction, glue it can be more noticeable at night. And that's because when you lay down and you're horizontal, the blood vessels dilate around your eustachian tube. That causes the eustachian tube to become more blocked and swelled, which then doesn't allow the ear to naturally equalise the air pressure behind your eardrum. So behind your eardrum, you've got your middle ear, that should be full of air, and what regulates the air pressure. So I'll just come back to that. You can see the patient's eardrum there, it's nice and healthy. Just going to mop up around the edge with the suction probe. And this tube, the eustachian tube, connects the middle ear, the cavity, to the back of the nose, the nasopharynx. The eustachian tube is typically closed, but during brief moments of yawning or swallowing or chewing, it momentarily opens and it allows either air to exit the middle ear if the air pressure is greater than the atmosphere, or it allows air to enter the middle ear if there's not enough air pressure behind the eardrum to be equilibrium with the atmospheric air pressure. But if this eustachian tube is blocked, you can't equalise the air pressure, and the cells in the middle ear, they absorb all the remaining air, all the oxygen, and then the middle ear becomes starved of air, and it creates a vacuum effect. Your eardrum gets sucked in. Now, my eardrums are quite hyperflaccid as well, so they're very thin, they're very mobile, and when it gets sucked in, it wraps around not only the hammer bone, but also the incus, also known as the anvil, and when it wraps around that, it can be very painful. And sometimes when I've been swallowing today, the eustachian tube's trying to open, and it's really sore, it's tender. Apart from not being able to hear very well from that ear today, I can hear my own voice inside my head on the left-hand side, the bad ear. So I'll come back to that in a moment. So you can see I've just used the ear hook to extract this matted dry wax and keratin plug out of the ear, just mopping up around the edge. The patient's got a nice healthy eardrum. There's a bit of skin at the back of the ear canal that I'm going to peel off using the suction probe. We're on the cartilaginous portion, so I can put a bit of pressure. So yeah, and we call that sensation of being able to hear yourself inside your head autophony. That's when you can hear your own voice inside your head. But if you hear other sounds, like when you're chewing or your heartbeat or your pulse, we call that occlusion. So occlusion and autophony are very similar. Autophony just directly relates to your own voice being heard in your ear. And it feels like I've got a bucket over my head. So the treatments we recommend, we're in the UK, recommend an Auto-Vent nasal balloon. It's a special balloon that you inflate using your nose. It comes with a nasal capsule, and as you blow into the balloon using your left nose, in my case, the left nose, it inflates the balloon. It forces air up the eustachian tube to stretch the opening of the eustachian tube at the back of the nose open so air can enter. Sometimes you can get a fluid build-up behind it in the blocked eustachian tube, and at the same time it allows fluid to drain. And I'm also using some over-the-counter nasal decongestants, and I've just started that today. It's already a bit better. Now, this morning, when I had a shower, and obviously all the steam, my ear did temporarily unblock itself, so steam therapy is quite good as well. So you can get hot boiling water in a bowl, some eucalyptus drops, menthols or crystals, towel over your head, inhale the steam. Now, this is my last patient. They got one of these online endoscopes, trying to remove the wax. I hope I didn't inspire them with my videos to try these devices. They only made it worse. They pushed it right up against the eardrum. They were experiencing severe pain. As you can see, made kind of light heart work of it. And job's done, really. Just going to mop up at the top of the ear canal, a bit of wet wax. Now, you'll see the right ear in the moment. The right ear, there's no wax in there, but they had also used the endoscope device. I think it comes with a little spade at the end. I don't know what they call it. And they were poking around. You can see the bottom of the ear canal's grazed. There's a bit of dry blood there. Advised, they can put themselves at risk for